We will be hearing from Mr. Bill Hanley and Ms. Sue Shettle regarding the convenings, and this does harken back to honoring choices. The issue here is we had indicated that we would indeed explore end-of-life services, and this is what we're going to discuss briefly today. We've had robust discussions on pharmaceuticals twice now, and I think the questions that the Senate panel offered were excellent. So having said that, if the presenters could come to the podium and introduce yourselves and begin, that would be excellent. Thank you very much, and thank you for joining us.
Great. Thank you, Mr. Chair, Senators. My name is Bill Hanley. I am not a medical industry person. I'm a media guy, and I was with TPT for many, many years. 37 years, I led the team that created Almanac, which was 1,000 years ago. It was about 6 or 7 years ago that I had what I thought was a really unusual experience that I now know many Minnesotans and many people in this room have had. My father, who was down at Fairmont at the time, called me and said, you know, your mom, who's 92 at the time, has been diagnosed by the wonderful people at Mayo with end-stage renal failure. And so they're beginning to talk to us about dialysis. And I said, well, Dad, what's the problem? What are you worried about? He said, she doesn't want dialysis. She doesn't want that care. She's 92, she's got other things going on, and we've talked about it, and we're sort of at a loss because the medical people are pushing appropriately, but pushing very hard for her to start this care, and she doesn't want it. And that began for my family, my sisters and my kids and all of us, a conversation led by the wonderful people at Honoring Choices Minnesota that you're going to hear from soon, a conversation, a family conversation about what are the choices that my parents wanted to make about the end of their life and the care that they had, and talking to my parents about the fact that they really could make those choices, and they could ask the medical community to honor those choices, even though it wasn't what the medical community wanted them to do. And my mom eventually did decide to skip dialysis. She got the kind of death that she really wanted. My father, at 95, felt very good about the process, that he was able to give her the kind of death that she wanted. And all of us, including my children, felt really good that we've been able to participate in the process and know for certain that that's what my mother had wanted. Now flash forward to a couple of years ago, and my friends at Honoring Choices approached me, and our friend Kathy Wurzer from Minnesota Public Radio, who was doing a project on end of life, called me and said, you know, we really want to figure out a different way to talk to the people of Minnesota about the importance of having family conversations about end of life before you get to the bedside, so that you could really, our loved ones could speak for themselves. How do we put together a collaboration, a partnership of people that can begin a statewide campaign to talk about end-of-life care and how a family can have that conversation? And so we began a project called the Convenings, again, 2 years ago, a fantastic, I mean really a fantastic collaboration amongst the CEOs of Health Partners and Alina and CentraCare, and then media organizations and faith organizations, media including Care 11 and our old friends at TPT. And so I want to show just a brief clip of something that aired on Care 11 this last year, and then talk a little bit about what the Convenings is.
Messages can be broadcast in waves.
Coming up here in Morning Edition, world, national, regional news.
They can also be carried in conversation.
We talk about it here a lot.
The conversation in Ely these days isn't what you'd expect.
Estate planning, end of life.
End of life. Planning.
Yes, death is on the table.
Because we're all old. We're old.
Yeah.
And because the conversation came to them.
Kathy Wurzer was up in town, who left her book that she wrote with Bruce Kramer.
I'm Kathy Wurzer. More to come here on Morning Edition from NPR News.
Kathy Wurzer started broadcasting her conversations with Bruce Kramer on NPR in 2011, shortly after he was diagnosed with ALS.
It was a life-changing experience.
An experience Bruce described as living while dying.
Bruce was actively dying, and I was with him at the end, and he said, I want you to look for the ripples in our work. And I said, I have no idea what you're talking about. What are the ripples? And he said, you'll know it when you see it.
Ripples are how interviews turn into a book.
Thank you. Thanks for being here.
And a book turns into the Convenings.
Everybody has a story. Everybody.
The Convenings are a community forum for end-of-life discussion, and they're here because they ripple.
So a year ago, my mother died.
Through Dr. Joe Bianco.
It was a wonderful thing.
Wonderful, because through his mother's death from Parkinson's, Dr. Joe learned the power of care directives and communication.
So when she died, we knew exactly what she wanted. It drew us closer. Just having the conversation was important.
And Dr. Joe turned to Kathy to bring that conversation to Ely.
I'm going to give you 5 minutes. Talk to your neighbors, unless you are Finnish or Norwegian, and then you're going to stare at your shoes, and I know that.
I haven't ever done any advanced care directive yet, but I'm going to.
It's a promise many put in writing.
It's a commitment card. I'm not asking for your firstborn child or anything like that.
I think it's real important that your loved ones know what to expect.
8:28 here in Morning Edition.
Kathy says that love is where this whole wave started.
I remember I was talking to Bruce, and he said, the Beatles were right. All you need is love.
What really has the deepest meaning of all is the love that I share.
So the Convenings is a series of live events which we've done in communities from Ely to Laverne to Coon Rapids and beyond, and some media work, again, to essentially begin to normalize this conversation about death and dying, and the fact that as patients we have choices that we get to make. My parents didn't really realize they got to make those choices. And the organization that is so central to this whole activity from the very beginning, 10 years ago, is the Twin Cities Medical Society and their CEO, Sue Shettle, and the Project Honoring Choices, which I just can't say enough about. And so with that, Sue Shettle.
Thank you. Thank you for having me. My name is Sue Shettle. I'm the CEO of the Twin Cities Medical Society and the co-founder of Honoring Choices and co-founder, actually, of the Convenings as well. I'm just going to talk a little bit about the project that we've been working on, as Bill said, for about a decade, called Honoring Choices Minnesota. Dr. Kephart will speak after me. He's our medical director, so I'm glad to have him here with me today. You know, our mission is to make advanced care planning the community's collaborative standard of care. So we're trying to normalize the conversation related to end of life so that it just becomes just part of who we are as a community. It's not about filling out forms. Oftentimes people say, oh, you're the people that want to have people fill out forms. It's more than that, much more than that. Of course, as a medical industry, we want to have that form in the electronic medical record, and we want to have that accessible. But what we're really trying to do is encourage people to have family conversations around the kitchen table. And I'll just start with a few facts, some of which you've talked about earlier in other testimonies. But we know that people aren't dying where they want to die. Some reports say 7 out of 10 people say that they want to die at home, yet 15% actually do. There's a big disconnect there. 70% of people actually die in hospitals, long-term care facilities, and nursing homes. We spend a lot in healthcare, as you all know, over 20% nationally, and I think at 32% in Minnesota is what I've seen. And then we know, too, that 28% of the total Medicare spending in the last 6 months of life is for Medicare is very high, and it's $170 billion from what I found. So we know hospice is underutilized, palliative care and geriatricians we don't have enough of. So as the medical society, our physician group got together and said, what can we do that would make a difference? And we landed on, we can do a better job around end of life. And so we started that journey about 10 years ago, and TPT was a great partner with us as we started that work. I'll just tell you briefly how we're structured, and I do have some handouts that hopefully you have in front of you there. But the Twin Cities Medical Society serves as the convener. We're the coordinator, we're the catalyst, we're sort of the home of Honoring Choices. But it really is a statewide initiative with statewide partners, including everyone that you think would care about end-of-life care. So nursing home, healthcare, AARP, people that come from all of those sectors. But we really have three main areas of focus, and so we work in the community. We have a lot of ambassadors and volunteers that work in the community to talk about end-of-life care in a culturally sensitive manner, whether it's in a mosque or whether it's in a senior community center, wherever. We have a large presence there. We also have a great presence within the healthcare sector. As a medical society, we're connected to the healthcare systems, and so we have, Ken will go into it a little bit here, but we have a fair amount of people, we have a lot of people trained, and we have a lot of things going on within healthcare. And then health and human services. So there's three different sectors that we look at. Community, healthcare, and then health and human services. And so I know that we want to allow a lot of time for questions from you. So I think I'll stop my presentation there and let Ken talk a little bit about some of our outcomes.
Thank you. So I'm Ken Kepler. I'm a physician, family doc. I've known your chair for a long time. Good to see you again.
Thank you.
You guys are amazing. I mean, I kind of have interest in a lot of the topics you were talking about. I had a hard time paying attention the whole way, and you guys have done an amazing job. I'm glad you're still with us, talking to us. But anyway, so I think the main point I want to make is that we've been active, we've had support in the health systems. They spent a lot of resources inside their systems and supported us to help normalizing the conversation. And it is about conversations that patients can have with their family members or trusted loved ones, so that when the time comes to make a decision, and the really important number I stress to people is, here's the deal. Most of us would like to die quietly in our sleep without any kind of disability or illness at the end of life. That'll happen to about 20% of us. The rest of the 80% of us will die slowly over the last several years with increasing disability, and about half the time you're going to be too sick for us to ask you directly what you want. That's why this is an important thing. You need to have somebody else that can step in, make decisions that you would want made, knows what you would want, and doesn't have to carry that guilt around the rest of their life. So I think that's just the kernel of what we are about. The healthcare systems have done a pretty good job, but they can improve on trying to capture what the goals of care are and recording it in a place where it can be found. But the one thing the healthcare systems can do, which is what I want you to understand, is the direct-to-community work for people who aren't really connected to the healthcare system. They're not touched until they have a major event, and then they're inside the hospital in a crisis, and it is very difficult to have a meaningful conversation about decisions when the patient can't participate in a crisis with a family member, not only doesn't know what they might want, but in a lot of times it has an inherent distrust of the hospital and the system, because they're not part of it, they're not comfortable with it. So one of the things we're doing that nobody else can do is go out into the communities, connect with the leaders in the community, whatever community we're talking about, whether it's a disadvantaged community, recent immigrants, refugees. We've done a lot of stuff by creating videos in 3 different languages to help bring this information so that discussions can happen in a place where people are comfortable. So it's not the first time they hear about this when they're in a crisis inside the hospital. So I think we're doing a lot of good work. Still a lot of work to do. And I think I'll stop there and ask for questions.
Thank you very much to all of our presenters, and I would take just a moment to share a story that when I was a senior medical student, Dr. Kephart was my intern at Ramsey Hospital on the burn unit and the surgical unit, and we talked late into the night about the philosophy of medicine, so welcome. Are there any questions or comments from the senators at this point? Seeing none yet, I will go ahead and start. I would like to first share a comment. I think the intersection that you provided us on the Honoring Choices handout that has got a sort of a garden growing under a brightly lit yellow sun does a wonderful job. What I so appreciate is, as a family doc who does indeed deal with death and dying each and every day, I appreciated that it's about the conversation. I'm afraid that so many times when we have organized efforts moving forward, it's about a checklist. And so once someone's done some quasi-advanced directive, whether it's a POLST form or whatever, they check it off and say, good, I got that done. And 5 years later, I'm asking, I don't have a living will in your chart. Did you do it? Oh, yeah, we did one. And I said, do you know where it is? No, but we did one. And I think that gets to the point that it's really about the conversation. And if you want to be transformative in our society, that conversation can be transformative, but filling out a piece of paper, signing the bottom of it is not going to transform. And when I had breakfast with you this morning, Bill, you mentioned that what you're trying to do is, within a generation's time, change the way our society approaches end of life. We've got a lot of scary terms and phrases out there now. When we start to talk about this, oftentimes phrases like death panels and things like that will intrude on the conversation and keep us from what we're trying to do. So I very much appreciated that. Also, I would do the unusual thing for me, because I'm somewhat of a skeptic when it comes to some of the government interventions that have the best of intentions. But the advanced care planning initiative that Medicare has put into place over the last year in terms of actually compensating physicians and providers to have the discussion regarding advanced care planning. I read an article the other day that they've more than doubled what they thought would happen in terms of the conversations around our country. I think they had expected, I can't remember if it was 300,000 or if it was, I can't remember what the number was, but it more than doubled. And I think that this is just the perfect time as we have this perfect storm of crisis with costs and things like that. So thank you very much for your work. Dr. Keppert, you have a comment
Mr.
to
Chairman,
make.
if I could just,
Please.
so not only does just filling out a form and putting it next to your will and safe deposit box where nobody can find it doesn't help, but having even a single conversation is inadequate unless you're going to need to use it in the next year or so. So part of the learnings is that it's a process of regular reviewing, because people do change their minds as they experience different diseases. So what they may say they want at 65 may be much different than what they want at 85. And so it's much, it's kind of like you think it's not that complicated, and every time you get deeper into it, you realize how important it is to have a process around this. And so it's having conversations and regular retouches to make sure that's still what you want, or maybe the person you picked as a healthcare agent is no longer living, or maybe they've got a cognitive impairment, or you're not married with that same person. So there's a big process around this to make it relevant, because the one thing we really can't predict very well is when you're going to die. Just that everybody will face it at some point.
Thank you, Dr. Keppert. And I think it was a lot easier to predict when someone would die 100 years ago, when the top three causes were pneumonia, followed by dehydration, followed by tuberculosis. But those three causes of death are no longer on the top 10 radar screen, really. Today it's heart disease, cancer, stroke, and oftentimes those are elongated processes. We're a committee trying to address the bending of the cost curve downwards. End-of-life cares, in some studies, indicate that 40 to 45% of dollars are spent in people in their last year of life. Were you king or a queen for a day and you had our job in front of you, where would you look to specifically go to try to bend the cost curve down, yet doing a better job than what we may have done in the past with the resources we have?
I think the meat, and this is what's happening, I think a lot of our healthcare systems around the Twin Cities and the state right now is when somebody becomes seriously ill, their goals of care need to be talked about directly, and predictable things like dialysis or pacemakers or ICU care need to be addressed in a timely way. And I think if that's done at the right time, the biggest thing around that that's prevented, I think, good discussions has been our hesitancy as clinicians to put prognosis into the picture. So they don't want to remove hope. But study after study show that patients do, for the most part, want the truth, want your best description of their care, of their status, and want to have time to have discussions with their family members about goals of care. If that's done meaningfully, there is some pretty good evidence that the value you bring to somebody at the end of life is much higher, and you'll probably save a dime. I mean, it's a pretty good value-based proposition to really increase the value of the patient's experience and the family's experience at the end of life, and probably save it's much I think, more meaningful for patient and family to be at home in the last, month of life than in an ICU, and a lot less expensive.
Dr. Kippert, approximately 10 years ago, Aetna, I believe, changed their insurance parameters regarding hospice. And they removed the necessity or requirement that patients had to sign off that they would not avail themselves of potentially curative therapies. And they also expanded the predicted lifespan from 6 months to 12 months. Those two things had the potential to drastically increase the usage of hospice. And in fact, that did occur with Aetna. And what they found overall was they were bending the cost curve downwards. Right. Do you think, or do you have any ideas on how we might take that lesson we learned from Aetna's behavior and put that into Minnesota public programs or in Minnesota insurance carriers, and how would we do that?
Well, I think the hospice benefit certainly can be looked at. That's probably more of a federal CMS issue, but they are looking at it and trying to decide if that how to blend palliative care and hospice in a more meaningful way so people can have goals of care, palliative care discussions earlier. I think that fortunately there are some actual payment changes that Medicare has done, which we want to make sure the rest of the insurances follow, because not only do they have the advanced care planning charge that's available now for never used to be, they also have several new charges this year for paying for prolonged discussions with family members instead of having to have the patient face-to-face when the patient's too sick or cognitively impaired. So they're paying for things they never used to that can help support having these discussions. And I would put it under the goals of care, palliative care, and not necessarily just hospice, to help people have a little smoother glide path toward the end of their life. And I think the one thing I will say that you probably don't want to hear, because I'm not sure it's bending your cost curve or the state's cost curve, but I do think there needs to be some address of the medical assistance payments, which are so low. There's so much cost shifting. There has to be some way to try to make that quite so steep. I mean, they're clearly under the cost of actually providing care. And so, something like some states pair it with Medicare or something like that. So there's not so much, so it's more transparent.
Thank you, Dr. Kippert. Senator Klein.
Mr. Chair, no question. I just have a comment for the group. And thank you so much for your work in, I would say, changing the culture of medicine. When I went through medical training in the 90s, on our hospital services, a death was really considered a failure, a treatment failure, and a failure on the part of the team. It was emotionally and academically approached in that way. You play that out to the final analysis, of course, you have a 100% failure rate, and it's been much more edifying to realize that all of our patients will pass on. And you talk about how individuals and families maybe don't want to have these discussions, and I can tell you, physicians at a time did not either, but it's become part of our duty to sort of address that and make those tough transitions happen for the benefit of the patient in an ethical and a meaningful way. And I think your leadership in starting those conversations has been essential. Thank you.
Yeah, Mr. Chair, I have neglected as one of my things I was supposed to do. We do have activities with the medical school and the nursing schools around doing a better job of preparing the clinical side of it to have these conversations. So that's part of what we're doing also.
Thank you very much, Dr. Kippert. And Mr. Bill Hanley and I did talk this morning about other possible ways of, if you will, penetrating our society with these kinds of conversations. Obviously, we could try to get it into the business world, but even trying to approach this into our universities and our higher education centers, that would be another area. And in those kinds of initiatives, oftentimes the legislature does play a role, although that would not be part of the purview of this specific committee per se. So having said that, did you have a closing comment, ma'am? Yeah, if you would, Ms. Schuh-Shettle will make a closing comment. Thank you.
I just have one request, and that is that currently when you renew your driver's license, you are asked if you have a health care directive. And right now, we are unable to get that data. I don't know that it's being captured. And that I think would help us. It's just one benchmark, but it would be able to help us to show that we are making a difference, at least in that sector, that people are reporting. You know, we could probably go back and capture data for a number of years. But I think if there's, that's a small thing, but if we could get some help from you in that regard, I think that would be helpful. And thank you so much for having us here today. The Honoring Choices program has been, as I said, we're starting our 10th year, and it's actually serving as a national model. It's being implemented in 12 other states, and Minnesota's a national leader. We didn't intend to be doing this, I think, as long as we are, but here we are. So thank you for having us.
Well, thank you again, and I have asked Andrea, our committee administrator, to follow up on your specific requests so that we can forward that to the appropriate committee over the next couple of months in preparation for the 2018 session.
Thank you.
So thank you very much. Thank you, presenters. Appreciate it. Are there any other questions or comments from the committee? Otherwise, we will adjourn, and right now our next scheduled meeting is October 12th, 2017 at 1 o'clock. Thank you very much. The meeting is adjourned.